protect wing.
Thank you very much, ladies and gentlemen. First of all, I present you what I think about the question of what outcomes might we expect using the automatics mode to facilitate the winning process. I summarize in 10 points are the following. First of all, we hope that reduced ventilatory-induced lung injury, try to apply for the duration of mechanical ventilation and protective ventilation, try to reduce the diaphragm-induced injury, as shown this afternoon, called ventilatory-induced diaphragm dysfunction, use less sedation, and this from the beginning to the end of invasive ventilation. We hope that it could be automatic. Second, the reduction of the winning duration, decrease the workload of the staff, and this automatic mode should be safe and cost effectiveness. And finally, we hope that it could improve mobility and survival using some LCT. Then, I summarize my topic on this slide that I performed to try to summarize the objective I developed. I consider that automatic protective ventilation and probably total ventilation could be summarized in three concerns. First of all, the low tidal volume and the PEEP. This is the descriptive of the two main components of the protective ventilation. In the second category are the recruitment maneuver to keep the lung open and to open it, and this called the optimal lung volume to avoid no volo trauma. Secondly, the respiratory rate, which allowed an optimal ventilation, that means minute ventilation multiplied by tidal volume, which is the CO2 elimination. About the PEEP, you have the component, the second point is the FiO2, with allowed an optimal oxygenation, with combined PEEP and FiO2. And secondly, the pressure, that means the plateau pressure with the surrogate of the alveolar pressure, and more recently we showed that driving pressure is probably a helpful pressure to monitor. And this allowed an optimal lung pressure which could avoid no barrel trauma. And then all this should be associated with an early weaning extubation process, which we'll call it the quick fast weaning process, and I hope that this could be maintained from the start to the end of invasive mechanical ventilation. This slide, I hope, summarizes what we hope all then to avoid complication of mechanical ventilation and to be more safer. Then, associated to this, when you put the patient in pressure support ventilation or in a spontaneous ventilation, you have, if you put on the y-axis the risk, sorry, not worse, and the level of pressure assist, you have two situations. If you is in under assistance, you have the complication of under assistance, as we showed in the previous presentation this afternoon. That means hypercapnia, increase of work of breathing, the respiratory distress, hypoxemia, atelectasis. However, if you have an over assistance, you could induce nosocomial infectious, neuropathy, diaphragm dysfunction, atrophy, asynchrony, hyperinflation, duration of mechanical increase, and this increased morbidity and mortality. Then we hope that the automatic mode could put the patient under a comfort zone, which could define the best zone optimal. This is the concept of the artificial intelligentsia put into the machine to deliver automatic mode. Then, what we should not expect, and this is probably more important than we should expect, use in overall patient. This is a mistake that's made by all physicians. Please consider that an automatic mode could not replace the expert physician, like the automatic mode in the plane could not replace the pilot. And then it could not also replace continuously the user and the monitoring. And it could not be fastly reassuring, and then it could not solve all problems by the machine and the patients. To date, you have two automatic systems of mechanical ventilation unwinning which are available on the market. First of all is the Intelligent Smart Intelligent with Quick Win from Hamilton Medical Companies, and the Smart Care from Draeger Medical Company. Both automatic mode control automatically the level of assistance in pressure support ventilation function of respiratory and decrease this assistance or increase in order to gradually wean the patient from the ventilator and maintain the patient in this optimal zone. This is a Intelligent ISV Hamilton ventilator, and this is a Smart Care one. The Smart Care one was mainly developed in the part of clinical approach by Laurent Brochard when he was in Créteil in France, and with Marc Doja in engineering, and he was the first who developed this in clinical aspect. And the Smart Care is summarized today by a mode that the objective is to maintain the patient in a range of physiological or supraphysiological tidal volume and tidal CO2 and respiratory rate physiology. Then the first version was to maintain the patient between respiratory rate 12 and 28, tidal volume above 300 milliliter, and an untidal CO2 less than 55 millimeter of mercury for all the patients, and less than 65 mercury for COPD patient. In the most recent development of this Smart Care, you can set as you want the range and the limit of respiratory rate, tidal volume, and also untidal CO2. And I am sorry. And this you can see, the objective is try to maintain, I'm sorry I don't have the pointer, to maintain the patient in the normal ventilation. You see the green point, and the Smart Care makes a diagnostic if the patient is in hyperventilation, hypoventilation, insufficient ventilation, tachypnea, and then increase or decrease the pressure support level. This is a patient, as you see here, and you can see in the record at the left of the part the variability and the variation of the tidal volume on the respiratory rate according to the variation of the pressure support level as seen by the airway pressure modifications. What about the clinical evidences on Smart Care? We have a very nice and large randomized control trial leading by François Lelouch and Laurent Brochard in center in Europe, mainly in French and Switzerland. And you can see, using Smart Care, in comparison to the standard of care in each center, the other showed a significant decrease in duration of weaning phase of the total mechanical ventilation, including the non-invasive ventilation after extubation. However, another study performing in Australia in a single center showed no significant difference using very similar design of the study. This is very complicated to explain. However, one of the main explanations is probably the ratio of nurse-patient, which is 1:1 in Australia, and which was 1 to 2.5 or 1 to 3 in France and in Europe. And then this may explain the difference. Then the message, probably when you have a ratio very low or low, you can probably obtain some positive results with using an automatic mode such Smart Care. About Intelligent ISV, you have a difference which Intelligent ISV is a machine that included all the period of invasive ventilation. That means including the period when the patient is or was sedated. That means is under controlled mechanical ventilation in the Smart Care. And this Smart Care including all the objective of the protective ventilation extended. As you can see here, all could be performed from the beginning to the end of the invasive ventilation period. And briefly, the mechanism is to maintain the patient in the 5 optimal zone. As you can see here, the oxygen saturation and tidal CO2, tidal volume, and respiratory pressure, that means the level of assistance, and the respiratory rate. This is considered the optimal zone, as I am presented in the green part. However, you have acceptable low, as you see here, and acceptable high values. You can also set the values that you could want to obtain. However, you have here the suboptimal high, which the machine should change, and you have also the suboptimal low value. This is the concept of the ASV model. We have about the evidences. We have Amélie, you are looking for Audrey is here. Sorry. This is the evidence is clinical. You have no large randomized control on the outcome, but you have randomized control with physiological values. This is a setting using, you can see the objective is elimination of the CO2, which is a ventilation, and the other objective is to maintain target SpO2, which is an objective of oxygenation. And this I present you, for example, a nice first study performed by François Lelouch. There are several studies performed by the group of Jean-Michel Arnal in Toulon. This was performed in Canada. The other used the ASV anti-event mode after cardiac surgery, just after a postoperative period. And in this slide you show, in comparison to standard mechanical ventilation mode, the anti-smart showed a rapid significant decrease in tidal volume, and here you show a significant decrease in FiO2 in comparison to the user, mainly the physician or the nurse. We take always time to decrease gradually the FiO2. And as you know, for example, the oxygenation and the relationship between oxygenation and the ICU mortality, it's always a UV curve shape. That means very high oxygenation, hyperoxemia, or very low hypoxemia is probably not good. And this was nicely presented by this wonderful study performed by Massimo Girardi and Mervyn Singer, and was presented yesterday as showing that high level of oxygen saturation, that means above 97%, induced a worse outcome in comparison to more conservative oxygen therapy with a target of oxygen saturation between 94 and 98%. And then the objective is trying to have an oxygen closed loop which allow to maintain in this tunnel the range of target oxygen saturation. This is coming from a mix of the two table of PFiO2 oxygenation coming from the two studies of the ARMA study. And then an example of one study performed by our group. This study will compare the classical mode, which was pressure support ventilation, in comparison to the anti-event mode. As you can see, we performed a crossover study. That means each patient is one control. The patient received first one of the both mode, that means PSV, which is a standard, or anti-event. As you can see here, you have the value from the top of the button, the PSV level. As you see in PSV, we change 1, 2, or 3 times a day. That means when the physician starts the on-call. And at the left part of the slide, you have always a change each cycle or each minute to reach the target tidal volume and the target CO2. The same is true for the peak value. As you see in the left part, you have no modification in this patient. The peak was around 8 centimeters of water, and instead in the right part, you see a modification of the PEEP value according, as you see here, the FiO2 combination to reach the SpO2 on the target desired by the physician. Also, the tidal volume, you have a more significant variability in tidal volume by the anti-event in comparison to pressure support ventilation mode. In conclusion, Could automated weaning mode improve the process? That was the question. My answer is yes, but probably in only selected non-difficult patient. What means non-difficult patient? Non-difficult ventilated or weaned patient, that the most simple, mainly post-cardiac surgery, post-operative surgery for a few hours, or simple. I don't know, we can call presented by Laurent and by all the speakers, the first group of the easy wean patients, and it could be helpful in this patient to wean time and other. But finally, this is my last conclusion, sedation and weaning, my point of view, sedation and weaning process are undissociable, and sometimes you can be the best ventilator expert or the best sedation expert. If you did not combine two, you lost two. Thank you very much for your attention.
Very interesting, but I guess your last slide pretty much summed it up. As you were going through your slides, I was thinking in my head, like, would I do it? What kind of patient would I do this to? And the only patient was like an easy patient. So, I mean, my big question is, has anyone thought of doing an economic analysis, a cost-effective analysis to this? Because that, especially in the North American setup, that probably is, the healthcare dollar is a big deal, right? So I would think if it saves the hospital a lot of money, then it's good, but if it doesn't, then on a healthy patient, I can pretty much do it myself.
You're absolutely right, and I share what you said, meaning this is probably different between countries. All the countries don't have the same healthcare situation. Secondly, as you know, the Monday is not the same work than Sunday or Saturday. I think it's the same everywhere in the world, North America or South Europe. And probably in this situation, we can improve the outcome of the patient, and we can obtain some positive results in terms of cost effectiveness regarding the population admitted in each ICU, and that's why the majority of the positive results were obtained in post-cardiac surgery patients. Maybe you can win, I don't know, 6 or 8 hours, multiplied by 1,000 patients, maybe it's interesting. But the main message I want to repeat is, it's probably only for the easy patient, not for difficult patients. Like in the plane, when you have a turbulence, it's probably the pilot should take the plane and not the automatic pilot. Exactly the same.
Anything from the audience?
Salvatore Maggiore.
Thank you, Samir. Very nice presentation. I get your point, but sometimes I see that it's not so easy to define the difficult patients. Don't you think that using systematically the system may also help to define who are the difficult patients? You know, it's just for screening. I put everybody in this system, and when I see that there is a problem, I understand that I cannot use this system, I must drive myself.
You have absolutely right, Reno. In fact, I don't know how many of you have an experience with automatic mode, please. Oh, wonderful. And then the first experience that we have all, that we said it not works, when, I don't know, the resident or your colleague comes and say, oh no, this automatic mode not works. More often, is a difficult patient. It's not a problem I'm sitting. That means you're right. That means probably you performed a diagnostic of difficult. And as always I repeat, never forget that the ventilation is only a symptomatic treatment. That probably when you have a patient who it's difficult to ventilate or to win, you have probably to see if the etiologic treatment is good or not. This is my point of view. But
anything else? So final question is, if
again?
Yes, one final thing, because can you make this smarter? If you like, what would you do to make this system smarter? Is there, and like if you were given the choice to make these systems smarter, or do you think this is pretty much it for now?
What is your next question?
We can talk offline.
Any other question? No. I think the two modes are really helpful. I like the two modes. Probably the concept and the two modes will evaluate, I think. And my concern is probably the teams who use generally in their unit one of the two modes as the gold standard probably have a good experience when you ask. But today we have a large randomized trial showing a benefit, and probably we should do this.
Thank you. Thank you.
Thank you very much.
All right. Up next we have Professor Gavin Perkins, and he's going to talk about use of the non-invasive ventilation to facilitate weaning.
So the first thing I'll say is I'm not Gavin Perkins, I'm Jim
You
Walsh
got
from Edinburgh,
what?
Scotland. Gavin Perkins had to go to London this morning and has been delayed on the train coming back. Some of you may be aware there's some stuff going on in London today. But he sent me his slides, so I'll do my best to give the talk he would have given. And I do have an interest in this area, and Gavin and I are collaborators. One for me, I don't know how I managed to do that. So, in terms of conflict of interest, we are funded at the moment to do a non-invasive weaning trial in the UK, which I'll tell you a little about, called BREATHE, which has finished recruitment and is in analysis, but we don't have any results to present to you. But neither of us have any commercial conflict of interest to declare. So clearly there are some advantages from invasive ventilation in terms of protecting the airway, managing hypoxemia and difficult hypoxemia, hypercapnia, and very effectively reducing the work of breathing and allowing us to clear the patient's chest with suction. But we all recognise there are complications as well. Importantly, barotrauma and volume trauma, but also effects on the cardiovascular system and long-term effects such as tracheal stenosis, as well as important other complications like sedation and delirium, which we've heard about, and pneumonia, ventilator-associated pneumonia, which is associated with increased mortality and more prolonged ICU stay and cost. So in terms of considering how non-invasive ventilation might fit into the process of weaning, I think it's useful to consider it as a staged pathway and considering where non-invasive ventilation and the current evidence for it fits into that pathway. And this reflects this task force from a publication from 10 years ago, which clearly breaks things down into the initial phase where we treat acute respiratory failure with whatever mode of ventilation is appropriate and other supporting therapy. But we then should constantly consider whether the patient is ready to start the process of weaning, where weaning means the process initially of reducing the mechanical support from the ventilator or the oxygen required from it. And then at some point we need some process of assessing readiness that we think trying some means of extubation is safe, and many people use either clinical judgment or checklists which have been published, and we published one which we used in our trial which predicted that patients would eventually be extubated, but not when, in terms of a trigger to start reducing mechanical ventilation, and then some mode of testing the patient's ability to breathe unaided, either through a progressive reduction of pressure support ventilation or similar, or more commonly now, a spontaneous breathing trial where we remove support. And we know from most published epidemiology, accepting there's differences between populations, that if you do a spontaneous breathing trial, around about 20% of most ICU, general ICU populations will fail that trial. And I guess that's how we're beginning to define a difficult to ventilate patient. But those who pass should go on to be extubated. But then we recognise that again, depending on the type of population, there may be anything up to about a 20% failure rate and reintubation rate. So we're interested in the role of non-invasive ventilation potentially in these different stages. So we know as a tool, it clearly has the potential to reduce the work of breathing, and it could reduce airway damage, but of course also it might reduce secondary infections because it has not breached the barrier and the protective physiological barriers that we have that intubation and ventilation does. And importantly, perhaps very importantly, it may reduce the need for sedatives because it removes the stimulus of the endotracheal tube, and I think there's no doubt that optimizing sedation and minimizing sedation is perhaps one of the most important things we do in our ICU to improve our patients' outcome. And there may be specific indications in left ventricular failure and COPD, and I'm aware some of the earlier sessions today have discussed some of these. So if you try and break this process down and first consider the period where we're trying to assess whether non-invasive ventilation has a role in the patient we have considered ready to start the weaning process and might either embark on a reduction with an endotracheal tube in or an early extubation and substitution with non-invasive ventilation as a mean to weaning. So this is, the available evidence was reviewed around 4 years ago by the Toronto group in a Cochrane review done very robustly, where the question they asked was whether invasively ventilated adults with respiratory failure of any cause who either were underwent early extubation with provision of mechanical support with non-invasive positive pressure ventilation versus what we might call conventional weaning with endotracheal tube altered important clinical outcomes as listed there. They found only 16 studies, and I'll present some of the key findings to you. Importantly, they broke down these studies into patients with COPD and more general ICU patients, and I think you'll see in the next few slides why that may well be relevant. When you look at mortality with COPD, there clearly appeared to be a mortality benefit from the early use of NIV to substitute for the endotracheal tube. Many of these studies were small, of low quality, and if you can see on the left the date of publication, they were all published before 2006. So I think in many ways this is historic data because we might argue that many of these patients would never end up on invasive ventilation because they would have been managed with non-invasive ventilation prior to intubation effectively because we have a strong evidence base for benefit there. But if we have intubated the COPD patient, the use of NIV following identification that endotracheal tube removal may be safe but require ongoing mechanical support seems logical and evidence-based based on this therapy. If you look at mixed studies, so the more general ICU patient that we mostly deal with, then the signal is uncertain and the point prevalence is for a null effect. But again, the number of studies, the total number of patients in these studies is less than 500. So that essentially tells us we have an inadequate evidence base for the general ICU patient. And when we look at weaning failure, which is likely to link to mortality as an outcome, we see the same sort of pattern. With COPD, we see at the top, we see a direction of effect that is statistically significant of benefit. And if we look at the general population, it overlaps the null. So we have uncertainty. And again, the quality of the evidence and the precision of the estimates very, very low. When you look at nosocomial pneumonia, and particular COPD, we see a clear direction of effect. And that would support the use of this method of weaning in that population. Although the only ride I would personally have is, I think there may be an ascertainment bias in these studies because it's easier to diagnose pneumonia when you're on a ventilator with an endotracheal tube where you can suction and take samples than when you're on non-invasive ventilation. But despite that, it fits with the benefit in that patient subgroup. And in a more mixed group, again, with the possibility of ascertainment bias, there is a signal there which seems to be of benefit, suggesting it might be a useful mode. And when they looked at other outcomes, then across the other outcomes they defined, there seemed to be quite a strong signal that non-invasive ventilation, having identified a patient, was ready to start the reduction of mechanical ventilation. If you extubated that patient onto non-invasive ventilation, a signal of benefit. So the implications of this is that the trials are fairly consistent, and if you look at number needed to treat, if these estimates were right, they would suggest this is a very effective therapy in our ICU, but they're all small, they may be giving misleading results, and they're quite dominated by the COPD literature, which may not be that relevant to much of our practice. So on the basis of this review of the evidence, we were actually commissioned in the UK by our National Institute of Health Research funder, who commissions most large trials in the UK, to answer a question about the use of non-invasive ventilation as a means to wean off the ventilator. And this is the BREATHE study. It is powered to a primary outcome based on time to liberation from ventilation in terms of all mechanical support, and it's powered to detect a 2-day difference. The sample size is 360, and eligible patients are those who've been ventilated more than 48 hours and who fail a spontaneous breathing trial. So essentially, patients are screened